Thank you. Good morning, good afternoon, everyone. Today I'll be presenting on clot management in a pregnant patient with May-Thurner Syndrome. I'm a second-year medical student along with Dr. Meena Khandelwal. So the goals of our case report today is to recognize May-Thurner Syndrome as a risk factor for deep vein thrombosis. Secondly, to understand the overlap of signs and symptoms of venous thromboembolism in post-thrombotic syndrome. And thirdly, to understand the complexity of management in deep vein thrombosis in pregnancy. So the case today that we're going to discuss is about a 28-year-old female. She's had 3 prior pregnancies and she's currently pregnant at 32 weeks gestation. She's had multiple admissions to the hospital for complaints of worsening leg swelling and pain. And a thrombophilia workup has been done and came back negative. So going back to her first pregnancy, there was no complications in 2012. Then in 2016, she became pregnant for the second time, and she presented with left leg pain and was diagnosed with superficial thrombophlebitis. She was treated with anticoagulant in the hospital, and then she was discharged without prolonged anticoagulation. Also to note, at this time, her BMI was 35, which we're assuming is an increase from her first pregnancy in 2012. So later that same year, she's 5 weeks postpartum, and she presents with left leg asymmetric swelling, and it's worsening. And since she's postpartum, we would expect the swelling to be going down. She shows 2+ pitting edema. There's pain on the posterior medial aspect of the leg, and imaging studies showed extensive progressive thrombosis of the great saphenous vein within 1 centimeter of the femoral vein. So the patient was fully anticoagulated with rivaroxaban for 6 weeks, and then she discontinued the treatment due to vaginal bleeding. In 2017, due to continued episodes in the hospital for swelling and left leg pain, a CT pelvis with contrast was done to confirm the diagnosis of May-Thurner syndrome. So May-Thurner syndrome is an anatomic anomaly, and you have compression of the left common iliac vein by the right common iliac artery where it crosses over. In addition, there's compression at the junction where the external iliac vein joins the common iliac vein. An ultrasound guided stent was placed in the common iliac vein across to the external iliac vein to keep that vein open and to hopefully alleviate the pain and the swelling. Also at this time, she was placed on a prophylactic dose of low molecular weight heparin. In this case, it was enoxaparin, 40 mg per day. Here is a diagram of where she had the SVT along the great saphenous vein. And because it was within 1 centimeter of the femoral vein, she was fully anticoagulated. In 2017, after the stent was placed, there's no improvement of the leg edema, but the pain did improve. And at this point, she developed a post-thrombotic syndrome. So there's hypopigmentation of her leg, 3+ pitting edema. A CT venogram confirmed there was no DVTs. And on physical exam, you could see palpable cords and varicose veins. At this point, because the swelling wouldn't go down, the decision was made to do an endovenous laser therapy to ablate the great saphenous vein. She returned to the hospital several times for leg pain and swelling throughout 2017, and there was no signs of DVT, and she was given prophylactic dose of enoxaparin. In 2018, during her 3rd pregnancy, a DVT was found in the left femoral vein at the proximal and mid-level in the 1st trimester. An ultrasound confirmed the DVT, and it also was confirmed on CT venogram that her stent had remained patent. The patient was fully anticoagulated with IV unfractionated heparin, and then when she left the hospital, she was given a adjusted therapeutic dose of low molecular weight heparin. However, she continued to show symptoms of post-thrombotic syndrome, which was that swelling, pain, varicose veins, and hyperpigmentation of her left leg. Currently, she's on her 4th pregnancy, and she continues to show to the hospital for episodes of leg pain and leg swelling. And because of this, an IVC filter was placed to try to alleviate these symptoms. And then an added benefit of IVC filter is that if the stent tends to migrate, if the stent does migrate, the IVC filter can stop it from moving past into the heart. So she's currently pregnant and she continues to present with lower left extremity pain and swelling. Here are ultrasound images of the DVT that she was diagnosed with in 2018. This is an image of the left femoral vein at the mid-level, and we can see the DVT is noted here. And then the left femoral vein at the proximal level, and the DVT is noted there. Also, Doppler imaging showed the left popliteal vein there's no flow present. And then for comparison, in the right common femoral vein, flow was still present. And then another image, this is still from the DVT she was diagnosed with in 2018. This is of the left femoral vein, and you can see here where there's no flow is where the DVT was. So what is May-Thurner syndrome? It's a congenital anatomic anomaly of the right iliac artery causing a narrowing or compression of the left iliac vein. And you can see on this diagram, this dark is the vein, and where the artery crosses over, you can get compression in this area. So this predisposes patients to proximal deep vein thrombosis due to deposits of intraluminal collagen and slow venous flow. Typical clinical presentation can come up a few different ways. You could have venous compression and the patient will have no symptoms, or they could be symptomatic with left leg pain and edema, spur formation, which is due to that intraluminal collagen depositing in the veins. And most commonly, May-Thurner syndrome is diagnosed after a DVT is found in a patient. So challenges of differentiating a DVT from post-thrombotic syndrome can be difficult because the symptoms really overlap. Typical presentation of a DVT is swelling, pain, warmth and redness in the involved extremity. Post-thrombotic syndrome typically occurs in 40% of patients who had a DVT, and those symptoms will include dependent swelling, discomfort of the affected limb. So in severe cases, it can lead to venous ulcers as well. Diagnosis of recurrent DVT is complicated by prior DVT with post-thrombotic syndrome because of these symptoms. Other venous disorders are similar, and it can kind of hide an acute DVT presentation that could be coming up. So diagnostic testing and imaging is needed to confirm the reoccurrence of a DVT. So in our patient's case, challenges included multiple and frequent imaging studies that were done, ultrasounds, CT scans, every time she presented with an episode of left leg pain and swelling, because it was hard to differentiate whether this is a recurrence of a DVT or this is just symptoms of the post-thrombotic syndrome. In addition, management of the patient was being done at community and tertiary hospitals. So there's a lot of data on the patient. There's inconsistent histories, and it's hard to follow a common history since she's been diagnosed with May-Thurner syndrome. So we would really advocate, and our patient would have benefited from a single thrombosis center to manage this person's case, to keep a consistent history, and it would have prevented multiple admissions to the hospital and multiple imaging studies. And then managing deep vein thrombosis in pregnancy is important. Pregnancy and postpartum increases the risk of thromboembolism by 4 to 5 times. And a VTE is one of the leading causes of maternal mortality in the US. Imaging studies are limited in pregnancy due to the fact that you want to limit radiation exposure, radon exposure, and then limiting information on direct oral anticoagulants and anti-factor X inhibitors during pregnancy. So typically the drug of choice is low molecular weight heparin, followed by unfractionated heparin and then warfarin. Low molecular weight heparin doses should be increased in pregnancy as well due to increase in maternal blood volumes and an increase in renal excretion of low molecular weight heparin. You're going to need a higher dose to see the same therapeutic effects. And it's also recommended in pregnancy to have to monitor anti-factor 10A levels per trimester, and then the target therapeutic range is listed here. So thank you for listening. I hope everyone took away, what May-Thurner syndrome is and how it can predispose to DVT, that it's difficult to differentiate DVT between post-thrombotic syndromes due to the overlapping symptoms, and some overview on the management of DVT in pregnancy. Are there any questions?
Thank you very much. I think, again, we can all identify with patients who have bad post-thrombotic syndrome and end up in the cycle of getting further thromboses and worsening symptoms of the PTS, then complicated by pregnancy. This definitely sounds like a very difficult case to manage. So there's a question that's come through asking if there's any evidence that iliac stents or prophylactic IVC filters improve outcomes.
I don't know if it improves outcomes, but it will prevent some, like if the stent were to migrate, it's not going to go past the IVC. So, and in pregnancy, it's really hard to visualize the stent due to you want to keep the imaging studies low, and you have to do a CT venogram. So you want to limit the imaging studies that are done.
Okay. And then a question asking, how was information and support shared with the patient?
So she has doctors close to home that she works with, and then when she gets moved up here, information is shared in person through her file or online through her EPIC history chart.
Yeah, and there are some specific queries that tend to come up in pregnancy, aren't there? Because pregnant women will often ask about the safety of medications in terms of the baby and management of delivery. So there's quite a few specific things to think about in this kind of scenario as well. Raza, did you have a question?
Yes, thanks, Jill. But firstly, Michelle, can I just say, great presentation for a year 2 medical student. If you do develop a future interest in thrombosis and you fancy coming to the UK to do some work or research, I'd be very interested to have a conversation with you in the future. That was a great presentation. May-Thurner's in itself is a challenge, and the use of stents, we're doing it with our interventional radiologists. These stents were obviously devised and developed for older patients with vascular disease. We don't actually know if these stents will last the lifetime of the patients, and we worry about stent thrombosis. I was interested that your patient's recurrent events, the stent remained patent, and so I suspect this lady's got a prothrombotics condition, even though we can't identify it in the laboratory. Have you kept the patient on some form of anticoagulant long term now, and if so, what?
Yes, long term she's on enoxaparin. And typically right now, since she's pregnant, she's on a therapeutic dose of enoxaparin long term, 120 mg per day.
So outside of pregnancy, do you think her long term anticoagulant will be low molecular weight heparin?
I'm not sure.
So she's allergic to warfarin.
Yeah.
So probably would be use a DOAC.
Yeah. So yeah, thank you. I was going to say, so we're beginning to develop some experience with using DOACs in these patients with stents, and there are some registries collecting data, and she may be one to add to a registry. But yeah, thank you. That was a very interesting case, and good luck with the rest of your training.
Thank you.